So in these two clips here that I'm going to share is a presentation of how I plan and progress a particular patient using the clinical reasoning process from a functional perspective rather than going into too much structural, okay? And I'm trying to force a little bit of a FMS thinking into it so you understand where we are at with it. So there's a few things involved. I've written down some key concepts that I've applied to these two cases. We're going to start with the very first case. It is a very simple paraspinal back muscles around here that gets a bit painful after she sits down for too long, standing up, feeling a little bit more painful, standing too long, feeling a bit more painful, walking too long, feeling a bit more painful. So basically, in a motor control sense, we actually are dealing with a hip-lumbar dissociative disorder. If you look into Shirley-Sharman's movement syndrome-wise, this is a active extender syndrome. Okay, so the person's held in a lot of high active extension through the lumbar without them consciously thinking about it, but that is a movement syndrome. So from an FMS perspective, the 7 FMS tests that we're doing, what are we focusing on? So I need to teach her how to stand, I need to teach her how to walk. The common denominator there is your hurdle step. So in hurdle step, we are aiming for a stick so that the truncal stabilize. We're trying to lift and pull it up. We're going to try to reach and lower down or heel down, and then we're going to come back and come back. Alright, so what does it involve? It involves some form of pelvic stability. It involves some form of hip extension through the proximal hamstrings control so that the person can rock through the pelvis, rocking the pelvis over the foot. The pendulum concept of walking, lots of concept will be thrown in these two presentations. And then also the knee maintaining in neutral. You don't want them to lock out the knee in hurdle steps stance. You don't want them to be a little bit behind here, so it's very hard for them to lift up this leg. You don't want them to collapse into the arches and they're just locking it from there. So the knee has to be in neutral. And then finally the ankle rocking motion, whereby the ability to lift up through here, reach forward, and then rocking on the sole, rocking on the calcaneus. Okay, so that is the FMS function that I am trying to improve. So whatever I do, I'll go back, give her some drills, and then reassess this movement. That's all I do. And as I put it down, bring it up and lower down. And I'm trying to see which habit pattern is the best at guiding her not to overwork through this area here. In terms of notes writing, it will have a lot of dominant notes around the phase 2 classified under gait retraining. Okay, so what do I do for it? There's a few drills that I probably will do. So we're going to apply PNF patterns. Okay, so the first PNF patterns that I'm trying to guide her. So imagine I am side lying here. I need to take a step forward here, but I end up using my lumbar spine involved rather than coming from my hip spine. So you guys might say this is the lower cross syndrome and so forth. Look, doesn't matter what you use, you still need to know how to treat it. Okay, so what I decided to do was to use a bit of PNF guidance because this patient struggles to have that body awareness. So I need to guide her the movement right and then strengthen the pattern so that when it translates to single legs hurdle steps for the walking, she can feel the immediate difference. Okay, I need her to feel that. And some patients may not feel it. Okay, but she has some back pain, right? So we started off using the pelvic pattern. The pelvic pattern that I'm choosing is the anterior superior. So I'm guiding her to lift it up this way and lengthening it down. Lift it up this way and lower down. Okay, so what am I trying to achieve here? As I lift it up, I create a stability there, and then from there I force a PNF D1 extension pattern, which then forces the proximal hamstring. You don't want them to come from quads, alright? You want them to come from proximal hamstrings area here. Tactile is very important, so you give her sufficient feedback so that she creates this. And then isometric hold, strong in that position. Isometric hold, strong in that position. So she ends up familiarizing herself, pulling this pelvis forward and up, and quads extend. And then when she was able to stand on this, she said, oh, my back pain feels quite nice. I can do this action here. So now when we're looking at this action here, what I noticed then is the opposite side hip is dragging along. It's not lifting up very well. So okay, I then add on combo techniques. Combo techniques from PNF with facilitate anterior superior pelvis, hamstrings, D1 extension, hold strong already. Then we ask her to move hip flexion. We move hip flexion. We move hip flexion. Those who attended the PNF course with me, you will know what to do. But boy, it worked out this leg, this core here. It worked the hip flexor. So in the end, you see her walking, one leg stride is so smooth and so good that the other leg stride is like so much shorter that it doesn't know how to expand through the hips and pelvis. Well, one thing about hurdle step is they hold the stick here and then they lift up. Then they lose out on the truncal rotation that comes along with a gait habit pattern. So what I did was I do an ipsilateral pattern, same side scapula, same side pelvis, go forward, hip down, hand up. So I do the same side patterning and then I'll go down, hand up. Okay, all this is done while she's side lying. Eventually, her brain got it. We went into slightly more functional position here, in standing, and I lift the leg up. In standing, I lift the leg up. In standing, I lift the leg up. And I purposefully do it one side. One side later, I ask her to go for a walk. And I said, what do you feel? Let her to interoceptively look into her body. Appreciate that lightness, appreciate that feeling of hers, which is very, very important part of motor learning. Because of motor learning, if she feels that this is painful, this is hard to do, and all that, then the brain will never learn. Okay, there's no such things as practice 10,000 times it becomes easier. No, it's the brain always likes to choose the path of least resistance. Hint, we're all lazy, right? But if you can actually teach her and she feels, oh, yeah, this leg, even just simple drills that I just taught while I'm doing this presentation, my leg on this side feels so nice versus my leg on this side just feels so draggy and all that. And the words that I encourage people to use are a little bit more emotional focus, because then you will find that they have a bit more deep-seated motor patterning inside here. More neural metrics is being engaged. Neural tags are being engaged. And that will then really help strengthen the movement pattern. Okay, so this is case number 1. I look forward to case number 2